And Becky, I will go ahead and turn it over to you. Thank you for being here today.
Thanks, Allie. My name is Becky Sanders. I am the Program Director for the Upper Midwest Telehealth Resource Center. So that will be the focus of our topic today. As you can see in our logo, the Upper Midwest Telehealth Resource Center does cover 4 states, Illinois, Indiana, Michigan, and Ohio. So we'll talk a little bit from a policy perspective on what's going on in each of those 4 states. As a regional telehealth resource center, you can see the UMTRC States here in the lilac color, and you can see all the logos. You'll notice that we are one of 12 regional telehealth resource centers. There are also 2 national telehealth resource centers. TTAC is our technology center. They're based out of Anchorage, Alaska. And our policy center is Center for Connected Health Policy. They're based out of Sacramento, California. All of these 14 telehealth resource centers were all grant funded through HRSA, through the Federal Office of Rural Health Policy and the Office of Advancement for Telehealth. The Telehealth Resource Center program has been around for about 10 years. It grew out of the need from several telehealth network grant program grantees who were providing assistance to other folks that wanted to start telehealth programs and then didn't have enough time really to devote to their own particular grant programs. We do have a national website with the Telehealth Resource Center. It does link out to all of the different regional and national resource centers around the country. There are monthly webinars that we do with the national group. We also do have a lot of common reimbursement, marketing, program generation models, all kinds of stuff like that on the national site. We're currently in the process of updating the face of the national site to bring it up into the 2010 decade, and I look forward to having that done in the next 30 days or so. So before we jump in too much, I do want to talk about some distinctions between telehealth and telemedicine. As we go through the 4 states that the UMTRC covers, we'll be looking at definitions of telehealth and telemedicine. Some states have definitions for both. Some states have definitions for neither. But I use the terms interchangeably. When I talk about telehealth, I really am trying to focus really on the entire field of telehealth using technology to advance care. And telemedicine is that clinical reimbursable piece of providing health care. I also want to stress that telehealth is not a service in and of itself. It's a delivery mechanism. We're using technology similar to how we're using providing this educational lunch and learn today. We're using technology as our platform to reach out to multiple folks in various locations and bring us all together for this educational event. Similarly, telehealth does the same thing. It brings together providers and patients who are not in the same location. As I mentioned before, there are many different definitions for telehealth and telemedicine. As you can see on this slide, there are actually 43 states that have definitions for telemedicine, 28 that have definitions for telehealth, and 2 states that have definitions for neither. And we talk about reimbursement. Each Medicare is as a national government reimbursement program, and then Medicaid is governed by each state under CMS. And each state is able to tweak the rules and the regulations for how they will reimburse Medicaid individually as their state. So 47 states and the District of Columbia do reimburse for live interactive video conferencing telemedicine. So that is kind of like what we're doing here today. I'm on a video platform where the patient and the provider can see each other and talk to each other interactively. That's what we consider live and interactive video. Store and forward is more like in dermatology or radiology, where an image is taken and then sent to a provider. So if you're in a rural health clinic, maybe your general practitioner takes a picture of a skin lesion and sends it to a dermatologist. A dermatologist may not really ever see or talk to the patient. They're just looking at that picture and then sending information back to the general practitioner. So only 9 states reimburse for store and forward. And then remote patient monitoring, this is a continually growing area. We'll see some legislation on this as we look at the 4 states. But remote patient monitoring, a lot of that efforts are focused on the 30 days after like a heart failure or heart attack or a surgery in the hospital and an inpatient stay. And then the growing area of chronic care management. There's a lot of remote patient monitoring going on there, and we'll talk about that a little bit more as well. The other thing we'll talk about and compare the 4 states that we have in our region is parity in payment with in-person. And this is a growing area as well. As the slide says, it's the most common policy change that we're seeing in the last couple of years in the state legislatures. So there's currently 27 states that have private payer laws, including the District of Columbia. And we'll see 3 of our 4 states have some type of parity law. So parity talks about, or is all about, will a private insurance company or a commercial insurance company like an Anthem or a Blue Cross or an Aetna or a Cigna or a Sagamore or a United, will they pay for telemedicine under their coverage? Medicare was one of the first to pay back in the 90s for telemedicine, and Medicaid followed suit, as we're seeing most states do offer Medicaid telemedicine coverage of some sort. As far as legislation in 2016 at the federal level, there's currently 49 different bills related to telehealth that are pending in either the Senate or the House. A lot of the different topics are common emphasis on making sure that veterans have access to care. The VA is a huge proponent of telemedicine within their own system. And there's a lot of talk about mental health reform right now, and making sure that patients are able to see behavioral health providers as appropriate. And there's actually also some things going on about cross-state licensure. We'll talk in a minute about the Federal State Medical Board Physician Compact. On the state side of legislation, there's actually 133 telehealth bills that were introduced this year in 2016. And those cover 30 different states across the nation. And their focus has been on reimbursement, professional standards, the need for in-person care, and prescribing over telemedicine. We'll see that in at least 3 of the states that we talk about today. And here's some examples, Indiana in our region, and 2 examples outside of our region, talking about how that provider-patient relationship gets established. Can it be established over telemedicine? And can prescription be issued on that first visit? Again, looking back at the national level, there's a huge focus right now in grants. We see this in our HRSA grants on outcomes and bettering patients' lives and helping them to better live with their diseases and have better outcomes in, if you're a diabetic, in your glucose and your A1C. There's a huge push in accountable care organizations moving from a fee-for-service healthcare environment for reimbursement to more of a value-based environment or value-based care. Triple aim, quadruple aim, those terms get tossed around a lot as developed by the Institute for Healthcare Improvement and Don Berwick. Again, the focus on chronic care management, specifically for diabetes, chronic heart failure, and COPD. One of the scariest things that we know and is really pushing this move in the way that we reimburse for healthcare in the United States is we know that if we don't do something to change the way care is delivered, that the healthcare costs by 2022 will be 19.9% of the United States gross domestic product. And compared to other nations, the United States has the most expensive healthcare system, and we have some of the worst outcomes. So let's move into if you guys want to have questions, if you want to chat questions throughout, I'm happy to pause here and see if there's any questions. I'm also happy to take questions at the end. Moving into kind of a policy level here. So we know that Medicare is, there's no regulations around payments, only conditions of payment. They will, if you bill for one of the CPT codes that's on their annual bulletin, then they will pay for that. Medicaid is, also under CMS, but follows, each state has different nuances in their state legislature and the regulations for how they will reimburse for Medicaid patients. So this is just a screenshot. This annual bulletin from Medicare is from the Medicare Learning Network. And every year they put this out, and they usually add several codes each year. This year they added codes for end-stage renal disease and broke it out by the age of the patient. And they also added some additional codes for inpatient and observation. So there's the 99356 for the first hour of observation, and then an additional payment for each additional 30 minutes of observation. So as we look at these, one thing that I do want to stress, if you're doing end-stage renal disease, home is not an eligible site, but the care could be furnished from an eligible site. Most insurance providers have a list, especially Medicaid and Medicare, have lists of eligible providers and eligible sites, originating sites where the patient is at, from which they will reimburse for care. Another change in 2016 is we saw, and I've mentioned chronic care management a couple of times, the rural health clinics and federally qualified health centers. Some states use the term encounter rate clinic because they bill a single rate. They don't necessarily bill by CPT code or HCPCS code. But in 2016, they could start to bill for chronic care management using that HCPCS code on their UB04 forms. Again, we see this chronic care management come up, and the Medicare code for this is 99490. It was introduced on January 1st of 2015. So to get reimbursement for chronic care management from Medicare, there must be 20 minutes or more activity with the patient. Now this can be furnished not necessarily by the physician, by any clinician that is supervised by the provider for that patient. The patient must have 2 or more chronic care conditions. And each 30 days, if they're using technology to help manage the care of that patient, they can bill this 99490. Now the national average on this code for reimbursement is $40.82. Each state's a little bit different, and some providers do charge copays against this that the patient would have to pay. So the implications of this, I've already talked about moving from a fee-for-service reimbursement environment to a value-based reimbursement environment. So with this code, CMS is really dipping their toes into the water to see what kind of care can be given to a patient using technology to help keep them healthier, develop healthy lifestyles with their chronic care conditions. We're also seeing, back to this slide just a sec, we're also seeing this with bundled fee payments for like hip replacements, knee replacements, and we're starting to see some introduction for some laws next year, different areas where they're going to start looking at stents and other heart conditions and doing bundled payments for that. Back in 2014, HRSA did release this data warehouse site. They changed a little bit the way that Medicare reimburses, and they do it based on RUCA codes and census tracts. So this is a website where you can go type in the originating site address where the patient is going to be and see if it is eligible to be reimbursed by Medicare. I mentioned the cross-state licensure a little bit earlier. The Federal State Medical Board, or FSMB, has an Interstate Medical Licensure Compact. There are, I believe, 17 states that have enacted this legislation. We'll see that in a couple of our states here in our region, and several states have also introduced this legislation. What this is a beginning. States enacting this legislation is really a beginning of this. There's no formal policies and procedures adopted yet. But what the idea behind this is that when a physician wants to practice in multiple states, that they can fill out one application, and that it would go to multiple state medical boards to receive licensure in those various states. So coming back to telemedicine and telehealth as a whole, there's several different domains or different types of care when we talk about telemedicine care. A hospitalist or a hospital and a specialist is one of the first ways that we saw telehealth be delivered, where a specialist might be in Indianapolis in an urban area working with a patient who's at their home critical access hospital or their home general practitioner's office, so that the specialist doesn't have to do a real rotation and travel out, spend a lot of windshield time traveling to rural areas, and maybe they would only go out maybe once a month to see their rural patients. And conversely, the rural patient doesn't have to travel into an urban area just to see their specialist. When we talk about integrated care, often we're talking about mental health or behavioral health providers, and having a interactive video set up with a behavioral health specialist or a psychologist or a psychiatrist, where that provider is also not traveling out to multiple locations. They can stay put in their one office and see patients all over the state or in multiple states if they're licensed and practicing in multiple states. Transitions and monitoring, this is kind of back to that value-based care and the remote patient monitoring area. So we're seeing lots and lots of growth in this area. Also, we're seeing tons of healthcare apps popping up, Fitbits and other devices like that for patients to help develop healthier lifestyles and healthier activity levels. So when we talk about barriers and challenges, if we've got all this reimbursement out there and there's lots of positive policy changes, why are more folks not using telehealth? Why is it not a common household term? It's a cultural change. Every time technology changes, it's a cultural change, and we're creatures of habit. We like to do things the way we've always done them. So it takes a special type of group or person to lead that change and to use technology and integrate it into the existing processes and procedures of a healthcare provider's team. So it's very important to have that champion. Sometimes the champion is a physician, sometimes it's a nurse. It could even be the CEO of a hospital. But the whole team has to work on this together. If you've seen one telehealth program, you've seen one telehealth program. There are so many variations, just like there's so many different types of care out there and providers out there. There are so many nuances that every program is unique in and of itself. So as I mentioned earlier, we do serve 4 states with the Upper Midwest Telehealth Resource Center: Illinois, Indiana, Michigan, and Ohio. And what we're going to spend the rest of our time looking at is the individual laws and regulations for each of those 4 states. So in Illinois, telemedicine is defined as the performance of diagnosing patients. And I'm not going to read all of these. You guys can read them, and we can make the slides available, and we're doing today's recording. You see here that there's an interesting inclusion in Illinois' definition of telemedicine, that a person located outside the state of Illinois, it's not limited to, the law doesn't limit this definition to people that are outside of the state of Illinois. And Illinois also has definitions and regulation. And again, we see telemedicine as the use of telecommunication systems providing medical services when the patient and the provider are at different locations. In their Department of Health, they define that as clinical services to patients by physicians and practitioners from a distance. We start talking about Illinois Medicaid. There's some interesting things here in their telehealth definitions. Again, we see the use of the word telecommunication system, lesser and greater medical capability, using multiple formats, text, graphics, still images, audio, and video. They talk about synchronous, which is real-time video, and asynchronous, or store and forward applications. They are one of those few states that do pay for store and forward. Illinois Medicaid does reimburse for video, live video reimbursement for occupational therapy. And this is one of the most interesting things in the state of Illinois, that there must be a physician or a licensed healthcare professional with the patient at all times. The eligible originating site providers and then the distant site providers are listed here. Interesting that it does include podiatrists, and there you see that term, encounter rate clinics. Again, for encounter rate clinics, there are some specific language in Illinois Medicaid about how reimbursement should happen. Also for psychiatric care, they do reimburse for that, except for group psychotherapy. And again, remember the qualification that there must be a licensed professional in the room with the patient at all times. Illinois does have a parity rule that was introduced January 1st of 2015. It comes just shy of mandating parity in the state of Illinois. It says if the contract covers telemedicine, then they can't force the patient to either be seen via telemedicine or not be seen via telemedicine. So the commercial reimbursement providers have been slow to adopt this new language in their contracts. Once you open up a contract for negotiations, everything is subject to negotiation. But the good thing about this parity law is it does legally define telehealth for the state of Illinois, and it does include parity with in-person care. There's difference in parity in coverage versus parity in payment. And some states it covers both, and some states it covers one but not the other. So here you see parity of payment, but not necessarily a parity of care.
My house at 515. My house at 515 because I didn't want to.
Well, that's a factor.
We're getting some feedback.
I was texting them.
Miss the shuttle, you know.
Thank you, Allie. All right. Let's move on to Indiana. This is where I live and Allie lives, so that's near and dear to our hearts. In Indiana, telehealth is defined. Again, you see telecommunications, information technology for health assessment, diagnosis, intervention across a distance. The telemedicine talks about a specific method of delivery services, medical exams, allowing a provider to render an examination to a patient at a distance location. And it excludes using telephones or other means of consultation that is not live interactive. Regulation in the state of Indiana, again, we're talking about telemedicine services for a specific method of delivery, medical exams and consultation, and Indiana Medicaid does reimburse for those. So in Indiana Medicaid, there are different schedules. It talks about scheduled remote monitoring of clinical data. Indiana is a little bit more forward in remote patient monitoring reimbursement than some of the other states in our region. Again, they're talking in the Medicaid regulations about delivery of certain types of services, exams, consultations. Again, the stressing of the video conference equipment. Indiana does not reimburse for store and forward. Indiana uses the terms hub site, where the physician is at, and spoke site, where the patient is at. Talks again about that face-to-face communication and using that video conferencing equipment to accomplish that exam. There is still some legislation on the books for Indiana Medicaid about distance limitations. And Indiana is currently one of 2 states in the nation that I'm aware of that have distance limitations. We'll talk about the other 2 as we go through the different states. But right now, for the state of Indiana, for Indiana Medicaid reimbursement, that doesn't matter what the distance between the patient and the provider is if your originating site where the patient is at is an FQHC, a rural health clinic, a community mental health center, or critical access hospital. If you are not one of those eligible sites as a originating site, then your sites must be 20 miles apart. So if you're in a general office visit, or if you're at a rural hospital that's not a critical access hospital, or if the patient's at an urban hospital, then those sites must be 20 miles apart for Medicaid to reimburse in the state of Indiana. Talks about medical necessity, reimbursement, what types of consultations are reimbursable, pharmacologic management. In here you see that end-stage renal disease. So here's the regulations in the state of Indiana about live video. Again, as long as certain conditions are met, and from the previous page, and it does spell out several different locations here and types of services that are not reimbursable via telemedicine in Indiana Medicaid. Specifically, outpatient surgical, ambulatory surgery, radiology, lab, long-term care facilities, community residential facilities, anesthesia, audiology, chiropractic, care. It's interesting here, care coordination services is here, but then there's payment for some remote patient monitoring, which we'll see that here in just a minute. Specifically says podiatric services are not covered, where in the state of Illinois they were covered. Services billed by school corporations are not covered by Medicaid. And this is fee-for-service Medicaid. We've got some other programs going on within the Indiana Rural Health Association about school care and telemedicine in schools. And a lot of the Medicaid provided in the state of Indiana is via contract with a Medicare covered entity. So they're not part of this prohibition against schools. Speech and therapy services, transportation services, etc. So let's talk about the parity law in the state of Indiana. This also went into effect January 1st of 2015. And here we have parity of coverage, but not parity of payment. So the coverage includes medical exams, consultation, behavioral health, including substance abuse evaluations and treatment. Again, we have the exclusion, does not include delivery of services through telephonic monitoring or any other telephone consultation. We were able to pass this in the state of Indiana to include parity in coverage, as I mentioned earlier, but not necessarily parity in payment. Now, I have not heard of any stories where telemedicine was covered by a commercial insurance provider at a different rate. I just want to state that the law does not require them. The regulation, Indiana Medicaid or the parity law does not require the parity in payment to be the same as in-person payment. It's not regulated, but for the most part, that's what we have seen. We have seen parity in payment. So remote patient monitoring. The other states in our region didn't have a lot on the books for remote patient monitoring, but we do have some things here for Indiana Medicaid. If they're licensed, if the provider is licensed as a home health agency, this does include remote skilled nursing visits to monitor and interpret a telehealth reading. So here again, we see those three chronic diseases, COPD, CHF, and diabetes. You have to have 2 or more of those. There has to be an event where they were either in the emergency room or had an inpatient hospital stay, and a licensed registered nurse has to perform the reading of the transmitted health information. So those are for Indiana Medicaid reimbursement. We did have another law pass here, became effective July 1st, 2016 in the state of Indiana, talking about how you establish that provider-patient relationship. So now a provider-patient relationship can be established on a telemedicine or video conference, live and interactive video conferencing visit, and a prescription can be written. But the prescription is restricted. It cannot be for a controlled substance. So in this situation, we'd be talking some type of antibiotic for sinus infection or ear infection or something like that would be the type of prescription that would be written. Again, there are exclusions. It cannot be audio only. It cannot be a telephone call or email or instant messaging or an internet questionnaire. Those types of things are not covered under this. It has to be a live, interactive video conferencing visit. All right, so that's the state of Illinois and the state of Indiana. Next, we're going to talk about the state of Michigan. So in Michigan, there is a definition for telemedicine. And again, you see that electronic media linking patients with healthcare professionals at different locations. It must be real time. Michigan Medicaid, we'll see, does not pay for store and forward. It must be interactive audio video. Let's look at Michigan Medicaid. So here we talk about the use of telecommunications technology, again, connecting a patient and a professional that are in different locations. And here's some of the language about live video for Michigan Medicaid. It does pay for inpatient consults, psychiatric diagnostic procedures, training services, diabetes, and end-stage renal disease. They do require, in the state of Michigan, Michigan Medicaid requires at least one in-person visit per month by a physician, nurse practitioner, or physician's assistant to examine that vascular site for end-stage renal disease. And here's more about the live video reimbursement in the state of Michigan for Michigan Medicaid. And the initial visit to the nursing facility service, that does have to be face-to-face. But they will pay for behavioral change intervention, substance abuse treatment, education services. In the state of Michigan, it does allow for telemedicine services to be used in addition to the required face-to-face visits, but not as a substitute for them. And here a little bit about the reimbursement for Michigan Medicaid. They can bill distant site providers, and providers at the distant site can only bill services listed in the specific telemedicine services database. For Medicaid, each state has their own provider database or provider manual where they list all of the qualifications, all the eligible sites, eligible providers, all of the details on their regulations. Michigan Medicaid also does cover speech, language, and audiology services. And this also can be covered through their school-based program, something different that we haven't seen in our other states. And here it talks about the patient's site can be at the school, at the patient's home, or another established site deemed appropriate by the provider. So here you're seeing a little bit of that home as a qualifying site where very, very few insurance providers reimburse if the patient is located at home, with the exception of remote patient monitoring. Here a little bit more about behavioral health in the state of Michigan. They do allow for telepractice of behavioral health therapy. Again, you see that term telepractice, using telecommunications, information technologies, encrypted patient data. And they talk about certain circumstances with those technology requirements. And the eligible providers are board-certified behavioral analysts, assistant behavior analysts, licensed psychologists, limited licensed psychologists, and qualified behavioral health professionals. And again, there's an exclusion not written as strongly as the Illinois regulations, but only able to monitor one child or family at a time. Michigan does have a parity rule. It went into effect back in 2013. So the contracts shall not require face-to-face contact, and they shall be provided by a licensed registered professional, and they're subject to the terms of the contract. So here we see parity in coverage, but not necessarily parity in payment. Michigan does have some pending legislation going on right now. You see 4 different bills listed there. The first 2 are all about that federal state medical board physician licensure compact. So they're modifying the process and adopting that compact. These are pending legislation that's not passed yet. And then this other one here, 753, it's talking about reimbursement, prescribing, and when it's okay to prescribe and not prescribe. I pulled the language of this bill. I'll read you just some snippets of it. It defines the term prescriber, defines the term telehealth, a telehealth service, and it says, except as otherwise provided in this section, health professionals shall not provide telehealth service without consulting with the patient about receiving the health care or obtaining patient consent. So here we're talking about patient consent, and then we're talking about a health professional who is providing a telehealth service may prescribe the patient a drug if both of the following are met. The health professional is a prescriber, so it's within the scope of their practice, and the drug is not a controlled substance. So again, we see patient prescribing, but not for controlled substances. And this is pretty common across the nation. There's so many cases of opioid abuse and so many horrific outcomes that legislative bodies are really cracking down on who can and cannot prescribe and how controlled substances can be prescribed. This last one here on the pending legislation allows for funds for medical care and authorization for development and expansion of services to special healthcare services programs. All right, so that wraps up 3 of our states. The last state that we're going to talk about today is the state of Ohio. They do have both a telehealth and a telemedicine definition. We're talking about practice of medicine in the telemedicine definition through the use of any communication, oral, written, or electronic, by a physician located outside of the state. Now, this is an interesting one as well. And then the telehealth definition, care delivered to the patient through interactive audio-video from a site other than the site where the patient's located. So that there are, and some states do have different qualifications or different regulations for providers in the state versus out of the state, or patients in the state versus out of the state. So in Ohio regulation, again, they use the terms electronic communications for providing health-related information and services, and not limiting here to physical therapy, and then talking about large and small distances. Telemedicine definition, or sorry, the telehealth definition, direct delivery of evaluation and management psychiatric services to Medicaid populations. Here again, synchronous, interactive, real-time electronic communication with audio and video. And in Ohio, they have some special rules for speech-language pathology, and they talk again about the exchange of information from one individual to a provider through an internet connection. For Ohio Medicaid, Ohio Medicaid was slow to start here, but on January 1st of 2015, they did start reimbursing for E&M services, or that evaluation and management services. Eligible distance site providers include physicians, MDs and DOs, psychologists, and federally qualified health centers, medical and mental health. They do not reimburse for store and forward, and home is not an acceptable place of service either on the originating side or on the distance side. Now, Ohio is the other state in the nation that does have a distance limitation. They do have a 5-mile distance limitation for all providers and all originating sites. It was very interesting as this legislation in Ohio, and they talked about did they want to have a distance limitation or not? I didn't have it on the slide, but in fall of 2014, so October 2014, Michigan, who had had a 50-mile distance limitation for Michigan Medicaid, got rid of that entirely. Indiana was working on a partial distance limitation for that 20 miles, so we've excluded several rural providers for Michigan Medicaid, but we do have the 20-mile in place for more urban healthcare providers. And then Ohio Medicaid decided to start providing services, but they included that 5-mile limitation. So it's interesting to see what contiguous states are doing. Ohio Medicaid does reimburse for live video for speech therapy services, and they do have a Medicaid school program for speech language pathologists. Now, as Ohio Medicaid was slow to pay for E&M services, they have not developed anything around parity of coverage or parity of payment to date. There is one pending piece of legislation in Ohio that is interesting. And again, just as we've seen in Indiana and Michigan, this deals with prescriptions via telemedicine and controlled substances. And the area of mental health and behavioral health, telepsychology and telepsychiatry services, this is one of the areas that we're seeing a lot of pushback about these restrictions on the prescription for controlled substances. Psychiatrists, there are shortages of psychiatrists all across the nation, and it'll be interesting to see, especially here in the state of Indiana, where we have this most recent rule regarding prescription for controlled substances over telemedicine, how this plays out. I think they're going to have to find a fine line in allowing the prescription of controlled substances for existing patients versus new patients who may need to be seen in person. But we'll see. I'm not promising anything. I'm just kind of guessing how things are going to go. So it'll be interesting to watch. All right, and there's my contact information. So I'm happy to answer questions. Certainly feel free to give me a call or send me an email after today if any other questions arise.
And I actually haven't had any questions come in for you, Becky. Did you get any in the chat function?
I have not.
Okay. Well,
I must have explained things perfectly.
Yeah, I'll go ahead and I'll forewarn everybody, we're going to unmute your line. So if you do have a question you'd like to ask, you're certainly able to. Today's slides will be available. I don't know if you saw that or not. Becky will provide them to me. And I would appreciate if everyone on the line today could use the chat function to send me your email address. That way I can get you copies of the slides and also can send you our follow-up survey. It takes less than a minute, but it is very important for us to be able to continue offering these educational programs. So if everybody could take a quick second to shoot me your email, we will follow up with the slides, and I'll also let you know when this has been posted to our YouTube page. And now I am unmuting everybody's line, so fair warning. If anybody would like to ask a question now, the lines are open.
And you would never know it's just a regular small.
Okay, not hearing any. I would like to thank everybody for joining us today, and a special thanks to Becky Sanders for putting on this very informational lunch and learn for us. If you have any questions, please do follow up with Becky or myself. I will send my email address out to everybody right now in the chat function, if I could spell it. Again, my name is Allie Orwig. Again, we appreciate you being here, and we're going to go ahead and sign off. So thank you, everyone.